Good afternoon to everyone present here with us today. This is Shriyon from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your moderator for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Asha Bakshi. Ma'am is MBBS, FICOG, FRCOG, MS, OBS and gynecologist and fertility specialist at Motherhood Women and Children Hospital, Indore. Ma'am is also Director and Chief of Ops and Gynecology at Disha Fertility and Surgical Center, Indore. With the help of Ma'am and her wonderful insight, we will be taking a close look on today's topic, which is impact of rising obesity in Ops and Gynae practice. Now, without any further delay, I would like to welcome Ma'am at our forum and would like to hand over the session to her. Over to you, Ma'am.
Thank you very much. And indeed, it's an honor to be at this platform. And today, I thought the topic I'll select is very meaningful because overall, the incidence of obesity is rising. There is a big epidemic, and you can see how the situation was way back in 1999, and then it is every day the incidence is going up. Not only in US, I think I would say all over the world. So, the global prevalence of obesity has increased in the past decades and disproportionately in females. So, females are bearing the brunt much more, and we are going to come across more obesity related problems in our day to day practice. So, it's all the more important for obstetricians and gynecologists to be aware of the problems related to obesity because the population that we are catering now is not thin patients, it's mostly overweight patients. So I think it's very important. And uh, uh, obesity affects not only the mother, but at the same time, the unborn, the offspring. And that is again very important, and it has its own complications. And the resultant mortality and morbidity from maternal obesity increases overall healthcare cost and poses a threat to the public health also. So, WHO 2016 data suggests that 40% women were overweight in 2016 and 15% were classified as obese, underscoring the widespread significance of obesity across countries of all income. And these days, we are seeing that it's not only adults, but even the children are getting affected. So, over 10 times more children and adolescents were obese in 2016 compared to 1975. So, overall, even when we compare how we were and how our classmates were, and what was the weight. And then now, those days, I still remember my colleagues and myself, we were somewhere around 37, 40. 45 was considered as really very good when we were in class 10 to 12th. But nowadays, a girl who is 40 kg, she comes and tells me, I'm not putting on weight, I'm very underweight and all. So overall, things are really changing. And and India is no less. And in India, every one out of every four person is obese. And age-wise, if we go, then the distribution you can see it is increasing, and it is affecting. The incidences started rising, especially from the adolescent, and continues till the age of 49. So, and these are all the various data concerning the rise in obesity in India. So, what is obesity? Actually, being overweight is defined as having a body mass index of 25 to 29. And if a person is more than 30 BMI, then that is called as obesity. And there are three levels that reflect the increasing health risks and that go along with increasing BMI. So obesity grade 1 will be BMI 30 to 34.9. Then category 2 will be 35 to 39.9. And category 3 will be BMI of 40 or more. And accordingly, there are overweight is associated with increasing increasing risk of disease. And if you are underweight, then your risks are again very less, are high. And if you're overweight, then again the risks are really high. And one can compare not only just with the weight, but even waist circumference. Overweight, obese, their waist circumference tends to be more than 80 centimeters. So all these are the parameters that can be used to find out what is your risk of having diseases. Then coming to body mass index in adults, BMI of 18.5 to 24.9 is defined as normal, while BMI of 25 to 29 is overweight, and BMI greater than 30 is obese. An increase in body water content in pregnancy makes the correlation of increasing BMI to morbidity less robust. BMI is still frequently utilized for screening and monitoring in obesity in pregnancy. So we all know that because of the fluid retention, just taking BMI in account may not be that helpful, but still it does have its own impact, and especially at the booking visit when the fluid retention is not much. That time, if you classify according to body mass index, then you can really find out, put a patient in a high risk group or low risk group. Then causes are excessive food, energy intake, lack of physical activity, and genetic susceptibility. That is the modifiable, that is the factor. Otherwise, what I would say, it is like a bank: more you put in, more you gain, and more less you spend, more you gain again. So this is what. But then there is some genetic susceptibility, and few cases are caused primarily by genes, endocrine disorder, medications, and psychiatric illnesses, and they all lead to insulin resistance and all that, and there may be more of lipogenesis and less of lipolysis. So certain modific, because some people really work very hard to lose weight and they are not able to lose weight, and some people just do a little bit of effort and they lose weight. So yes, there must be some other factors just besides food intake and physical activity. Then medical complications, you name a complication and it is related to obesity. So right from sleep apnea, lung diseases, liver diseases, gallstones, all sorts of cancers, especially for us, CA breast, uterus, all these are related to obesity. Then stroke, heart diseases, pancreatitis, abnormal menorrhagia, infertility, or arthritis, and all the things are related to obesity. So I think everyone, whether you're obstetrician or gynecologist or a general physician or a physician or orthopedician, you have to take obesity into account. So coming to reproductive health. Now, maternal weight gain again is very important. Whenever the patient comes at the booking, then it is very important to check her weight. And then you should give her a target that you should not put on more than this much weight in your second and third trimester. And usually, what I tell to patients, that till 5 months, that is till 20 weeks, you really don't need to put on the weight because you have enough, and baby does not need much calories and all those things. So you don't really. It is only after 20 weeks that the baby starts gaining the weight, so you can put on some weight. So if I tell them that, then also they come with at least 4 kg, 5 kg weight gain. And many times you see that in first 20 weeks only, women have increased their weight by 10 kgs or so. So very important to warn them right from the beginning that usually in first trimester we do not want weight gain more than 2 kg, and I don't just take it up to first trimester, I take it up to almost 20 weeks. And then if the patient is underweight, then for her 12 to 18 kgs is allowed. If she is normal, that is 18.5 to 24.9, then 11 to 16 kgs. If she is overweight, 7 to 11 kgs. And if she is obese, then only 5 kg to 9 kg. And I would say don't even say 5 kg, make it 4 kg, make it 8 kg, because whatever said and done, they are going to put on weight. But if you really put some strict criteria, then they will be able to control it up to some extent. And sometimes it may not be possible, especially if they have this fluid retention and all those other things. Now, maternal obesity leads to insulin incidence. There is increased incidence of all sorts of problems like that during pregnancy, diabetes mellitus, problems with induction of labor, coagulopathies, anesthetic, preeclampsia, fetal and neonatal complications, and when in utero effect of obesity leads to adverse effect on the offspring health also. Obesity is associated with DVT, hypertension, respiratory complications, cesarean section, and even in cesarean section, the morbidity is increased, and even there is increased incidence of postpartum complications. So, in pregnancy, there may be, as I've already discussed, miscarriage may be high, preeclampsia is because almost it has been said that almost 50% of patients may have obesity as one of the elements for recurrent pregnancy loss. Then preeclampsia 3 to 4 times is more. Gestational diabetes is 3 times more common. Thromboembolism is common. So whenever you talk to these patients, you have to talk with certain statistics these days. So these are the statistics. And gestational diabetes, I think this has become like a epidemic in our pregnant patients, and especially if you are doing infertility and you have had PCOS patients, then you have to be very, very careful about gestational diabetes. And sometimes you may not be able to pick up in the first screening test. What we do is a gestational, we do glucose challenge test, but many a times it comes afterwards. You can see that acanthosis nigricans that is increasing, weight is increasing, patient looks as if something is wrong, and then I think in between also we should randomly check blood sugars in these patients. Then sometimes the only indication may be that there is excessive weight gain on ultrasound. When you do serial ultrasound, you find that all of a sudden the weight. Today only I had a patient who is who has got a mild just glucose impairment during pregnancy. But then we did a scan 2 weeks ago, and today again we did. The growth is really, it has escalated like anything, and the fetus is large for date, and it is 4 weeks difference. It has outgrown by 4 weeks. So we are really scared. And today again I have sent her back to the endocrinologist. I think she should be started on insulin. So I think we have to keep those indirect markers also. We should just not depend on our one single screening test, but other things also we should keep in mind. And we know that pregnancy itself is diabetogenic state, and there is a decrease in insulin sensitivity, and this resistance increases the risk of GTM, various associated complications, which we have already talked about. Miscarriage, we have already talked that hyperglycemia during organogenesis has been linked to increased risk of miscarriage and congenital anomalies, and excess body weight has been associated with high risk of first trimester miscarriages. Then thromboembolism, I think this is again in many years ago, we thought that thromboembolism is the problem of the West, but with the increasing awareness and investigations, availability of the investigations like Dopplers and all, now we know that yes, this is a problem for our country also. So because we know that pregnancy itself is a prothrombotic state, and advanced maternal age, high parity, cesarean section, prolonged cesarean surgery, or these are all the risk, and obesity itself, these are all the risk factors for venous thromboembolism. And especially BMI of more than 30 doubles the risk of thrombosis by elevating thrombotic factors, and but it does not increase fibrinogen levels. Then BMI more than 25 combined with oral contraceptive pill, though it is not important during pregnancy, but as such, if a woman is overweight and taking oral contraceptive pill, then her incidence of having thromboembolism is increased. So I think whenever we are prescribing oral contraceptive pill, then we have to keep this in mind. Then even not only that, even labor, the progress of labor is affected by the incidence of obesity. Though obese women usually have prolonged first and second stage of labor, and there is early maternal exhaustion poor bearing down efforts leading to increased incidence of instrumental deliveries. And mind you, even instrumental deliveries in these patients are not very easy. And fundal pressure, it is very difficult to give fundal pressure also, because of that fat you can't even locate the fundus. Then there may be mechanical problems in head delivery due to the soft tissues, because these soft tissues also lead to sort of cephalopelvic disproportion. Then this may lead to obstruction. There may be malpresentations and macrosomia. And we all know that obesity, maternal obesity is associated with fetal obesity, and this macrosomia can ultimately lead to shoulder dystocia. So ultrasound on labor table may be useful, and because otherwise it is very difficult to assess the progress clinically. So I think it's time that we start using ultrasound during obstetric management also. I mean to say during labor also. Then cesarean section, whenever you do cesarean, then that is associated with more post-operative complications along with blood loss, DVT, wound infection, postpartum wound, uterine infection. Then obesity has been associated with intrapartum complications and vaginal operative deliveries. And even the post-operative, the wound also, cesarean wound tends to get more infected because that flap of the fat and the abdominal wall falls just over the phalansteal incision, and then that may sometimes get infected. So we have to ask the woman to keep it very dry, and most of the times I ask them to lift the abdominal flap a little bit and use, after having a shower and cleaning it, they should really dry up with the hair dryer. It's not me. Yeah. Now, fetal and obesity related perioperative events, there is increased anesthetic complications. Many times, just citing the Venflon, the cannula, the IV cannula is so difficult in these patients. They get surgical site infection. There may be deep venous thrombosis, delayed wound healing, gestational diabetes, preeclampsia, postoperative respiratory issues because of the increased abdominal pressure, and then cesarean section complications. All these things are related to poor perioperative outcome. Then fetal and neonatal complications, increased incidence of miscarriage and stillbirth. Neural tube defects are also more common. Macrosomia we have already discussed. Then congenital anomalies like neural tube defect, the spina bifida, then omphalocele, cardiac defects, they are all very common in obese patients, and many times it is complicated by the gestational diabetes also. And there is increased risk of operative delivery, poor delivery outcomes, and maternal and infant traumatic injuries. So, and the anomalies that are associated with pregnancy and in obese patients are neural tube defect, cardiovascular anomalies, septal anomalies, cleft palate, cleft lip, anorectal atresia, hydrocephalus, limb reduction anomalies. And so overall, obese women have a five-fold time increase in intrauterine death as well as infant mortality rate. And there is a correlation of maternal BMI and infant mortality rate. So postpartum complications, most of the complications we have discussed, but even breastfeeding is an issue. And these women, they have poor lactation, and latching is difficult overall because they are obese, so they are not able to really give a comfortable position to the baby, and overall lactation is not that excellent in these patients. Now, if you have to do surgery, even you may say that, okay, we'll do laparoscopic surgery, but laparoscopic surgery in such morbidly obese patients is also not that easy, though thanks to the bariatric surgery, people have devised special instruments for the obese patients, and special and even the anesthetists, they are getting more used to giving anesthesia to such obese patients. Otherwise, we may say that overall laparoscopic surgery is better for obese patients, but to get the entry and to have such long instruments is also very, very important. And post-operative management and a good perioperative care is necessary for these patients. Oxygen consumption and carbon dioxide production are more pronounced in obese patients. Excess body weight around the ribs, chest, under the diaphragm, and intra-abdominally causes reduced chest wall compliance. General anesthesia and steep Trendelenburg position reduce the functional residual capacity, and obesity is an independent risk factor for thromboembolism, which is almost up to 2%. Then patient positioning is very important in these patients, and we need special tables. The routine tables that we use for our patients are not helpful in these patients. So you should have proper special OT tables which are meant for obese patients, where they have a good support at the shoulders, especially if you have to give Trendelenburg position, because intra-abdominal pressure is so much that and overall the pressure is so much that the patient tends to slip down. So it's very important to have good shoulder supports in these patients, and the width of the table should be more, and the table should be very sturdy. So very, very important that patient positioning. And whenever you do patient positioning, it's we have to be very, because they tend to have arthritic problems. So we should see to it that we do not lead to any injury to the hip or to the knee. And neurological nerve compression may also occur. So we have to be very, very careful while positioning these patients for anesthesia. So bowel preparation is again important, because and another thing is that the umbilicus is migrating caudally in these patients. So you have to have a clear knowledge about anatomy in obese patients, and your port placements should be accordingly. So the initial entry point should be selected to provide optimal triangulation and visualization of disease. So all your ports should be placed in such a way that you can have all the ports in a triangular manner, and you can visualize the disease properly. And trocars should be positioned more lateral and more Kiffel head, that you can see here that they have to be more lateral and more Kiffel head in obese patients as compared to the normal patient. A fatty or redundant rectosigmoid calculon may be managed by using a puppet stitch placed through the epiploicy appendices with the attachment of a stitch to anterior abdominal wall or left quadrant. Then impact of obesity on clinical and financial outcomes is again important. There is increased operating time, so and blood loss is also more. Then there are adverse events increased by increasing obesity. So overall, there is no difference in length of stay or rate of perioperative events, but then overall the management and the care and the instruments and the anesthesia, they increase the cost of surgery. Now, PCOS and obesity, I'm not going to talk much, because most of you are well aware about it. But still, we know that, and there is no clear-cut formula that the patient, what sort of BMI is associated with PCOS. But we know that in PCOS, there is a tendency to obesity, and obesity further worsens the PCOS by affecting the insulin resistance and compensatory hyperinsulinemia, which increases adipogenesis and decreases lipolysis, sensitizes thecal cells to produce LH stimulation. So overall, there is change in the hormonal scenario, and leads to more of anovulation, and there may be excess androgen production, which may have its own effect. And there is some inflammation also, and this inflammation may be affecting the implantation and quality of the embryo or the oocyte. Then so all these hormones are affected by obesity, and there is reduction in receptivity of endometrium, atresia of early follicle, apoptosis of follicles. All the inflammatory markers are increased. There is insulin resistance. There is decrease in SHBG, and there is decrease in GnRH from hypothalamus. So if you have to stimulate these patients, then you have to give more gonadotropins. Now coming to ART, in ART, overall the response to medication like clomiphene and letrozole is reduced, and we have to increase the dose. It again impairs the responsiveness to gonadotropin stimulation, and we may have to give higher dose and for longer time. Then there is a chance of cycle cancellation also, and the oocytes retrieve may be less. And the quality also, people have said that obese women have altered follicular environment with higher levels of insulin, markers of inflammation, and elevated levels of fatty acid. And at the same time, there is mitochondrial dysfunction. Therefore, the oocytes tend to be smaller. There is decrease in plastulation rates, and however, there is no difference in euploid embryo rates or live birth rates. Now, it doesn't only affect the females, it affects the male also. And 79% of men who report having erectile dysfunction are obese, and overweight and obese men are at higher risk of oligozoospermia. And nowadays, we are doing DNA fragmentation of these patients, and we find that the incidence of DNA fragmentation is also high in these patients, ranging from 21 to 27%, compared with 15 to 19% in men with normal body weight. And epigenetic changes are seen from sperm in obese men. And overall, when we do IVF, then the rate of blastulation from day 3 embryos to day 5 embryos, that is also less. So it does affect. So it's very important when we see the patients in our clinic, in infertility clinic, have a look at the husband also. All the time we are after the woman, but just have a look at the husband also. He may be overweight, so maybe it's worth counseling that person for a decrease in the weight. And pelvic floor disorders are again very common, and urinary incontinence is very common amongst obese women. There are longer surgical times required in obese women for surgery, and even after the surgery for incontinence, the recurrence rate is high in obese women, and reduction in body weight by 5 to 10% has been shown to lead to significant reduction in urinary symptoms in women. But though prolapse is there, if prolapse is there, that does not get affected and that does not get any better. But if someone has got someone who is obese and has got urinary symptoms, maybe we should try asking her to reduce weight, and that may help with the urinary symptoms. Then cancer, you name it, and that cancer is related to obesity, right from meningioma to adenocarcinoma of the esophagus, multiple myeloma, thyroid, liver, gallbladder, and amongst all genital cancers also, say breast, uterus, ovaries, all these cancers are also affected by obesity. So, endometrial cancer, overweight, and obesity is estimated to account for 41% of endometrial cancer, and that's why you see these days because I work in a hospital which caters to middle class and higher class, and I'm seeing high incidence of endometrial cancer. Hardly these days I'm coming across cancer cervix, which used to be one of the time commonest cancer. But these days, endometrial cancer, I think every month I see at least 2 cases or 3 cases of endometrial cancer. So each 5 kilogram of increase in BMI is associated with 60% increase in endometrial risk. So endometrial carcinoma is really on a rise, and partly it can be attributed to increased incidence of obesity. Then ovarian cancer, again, each 5 kg increase in recent BMI, there was 13, 19%, and 17% risk of having low-grade serous, mucinous, and endometrioid ovarian cancer. Then cervical cancer, women with BMI of more than 30 or who have gained more than 10 kg weight from age 18 do appear to be at twofold elevated risk of cervical adenocarcinoma compared to women with normal BMI. And there are reports that adenocarcinoma is more commonly being found these days than the squamous cell carcinoma of cervix. And there is no increased risk of squamous cell carcinoma. So it is the adenocarcinoma which is associated with obesity. Then vaginal and vulvar carcinoma, higher post-excision occurrence rates have been found in women with BMI more than 30, and this could be because of surgical difficulties during surgery, because exposure is not that great, and maybe that is one of the causes. Now, breast cancer, increased impact is seen in postmenopausal women, worse disease-free and overall survival, higher complication rates during surgery, radiotherapy, and chemotherapy, and there is increased risk of local recurrence in case of obese women having CA breast. Now, adolescents are now no less, and there is a new epidemic of obesity in adolescents. The report of World Obesity Atlas 2023 shows that in 2020, boys in India had a 3% obesity risk. By 2035, the risk is likely to go up by 12%. And for girls, the risk was 2% in 2020, but in the next 12 years, it is expected to rise to 7%. Now, psychosocial risks again are associated with obesity, and adolescents who are overweight or obese at are high risk of low self-esteem, distorted body image, depression, anxiety, discrimination, and strained peer relationship. And women who are obese in late adolescence and early adulthood complete fewer years of advanced education, have a lower family income, lower rates of marriage, and higher rates of poverty compared with their non-obese counterpart. Bullying and peer victimization can lead to a range of adjustment difficulties, anxiety, and depression amongst these adolescents. So, and contraception also is a bit tricky in adolescents, because with COC, adolescents, there is increased risk of failure. Levonorgestrel and ulipristal acetate-based oral emergency contraception may be less effective but can be prescribed. DMPA ring, there is no problem. Intrauterine devices can be used, but there may be difficulty of insertion. Then coming to menopause, it has been shown in most studies to be associated with later onset of menopause. So that is one of the good things, that menopause is late. But perimenopausal women with obesity experience more severe vasomotor symptoms, and there is higher incidence of sleep apnea and genitourinary conditions. And we know that sleep apnea is its own metabolic problems, and there is fourfold rise in the risk of cardiovascular morbidity. So very, very important to prevent obesity. And let's talk a little bit about preventive measure for obesity. So diet and exercise during pregnancy is very important. So I tell them not to eat for two, be vigilant, do mindful eating, think about what they are eating and what is its calorie value, what is its protein content, what is its fiber content. Then exercise is again important, and as soon as the patient is pregnant, she stops working and she takes rest. So I tell them that continue with whatever you were doing before comfortably. Don't overdo the things, but don't underdo the things. So this is how we can. And even during our baseline booking, we should make sure that they do not have any coexisting diabetes and hypertension. So it's very important that they eat normal food in first trimester, because in first trimester no additional calories are needed, but in second trimester they can add additional 200 calories, and in third trimester 400 calories. So not more than that. So again, I think yeah. So there are various dietitians should be involved, because in our busy practice we don't have much time to advise them about diet, but we should be aware of what the food they can take. But I think it is better to take help of the dietitian. Psychosocial support is very important. We should really be empathetic to these obese people, and we should not really make mock of them. And but at the same time, we should focus on promoting healthy lifestyle rather than on body weight alone. Tailor information according to individual needs and values for greater meaning. And women's concern like nausea, vomiting, fatigue during pregnancy should be addressed properly, and they can be reduced by exercise and taking non-fatty food. Dispel the myths, that is eating for two, by explaining physical changes in the pregnancy, that is excessive food intake may increase maternal size. And medical management of obesity may be many beneficial when in conjunction with lifestyle measurement. Most result in weight loss during temporary effects on appetite, and thus patients may reduce energy intake and increase energy expenditure in the long term to sustain weight achieved with medication. They work primarily on promoting satiety through stimulation of pro-opiomelanocortin neurons in the arcuate nucleus, often mediated via serotonergic or dopaminergic or norepinephrine releasing agents, reuptake or inhibitions. So, and there are lots of weight loss medication, and some medications in US are so popular that it's really they are usually out of stock, and the overall the in shares also those the prices of those stocks have gone up. So bariatric surgery is one of the most effective intervention for weight loss, but these procedures they reduce the capacity of the stomach, but then there may be malabsorption of the food, and patients lose up to 70% of excess weight in 12 months. But again, proper counseling is important. These are the various types of surgery. So, Mike, basically, the key takeaways of this talk is obesity is a global pandemic, and we all have to be well trained, well prepared, and well equipped to deal with this type of population. Obesity, particularly in pregnant women, constitutes a serious risk for both mother and fetus, and the impact of which increases with the degree of obesity. Preventive measures include maintaining a healthy weight before pregnancy, adopting a balanced diet, engaging in regular exercise, and seeking prenatal care early on. Medical supervision is needed to manage weight gain during pregnancy and reduce potential complications. So, it is important to sensitize and educate women regarding weight related problems, and the importance of diet and exercise should be emphasized. So, at the end, I would like to thank you all with this picture of Bhumi Petnikar, where she has been so smart that whenever she wants, she puts on weight, and whenever she wants, she can reduce weight. I wish this was true for all of us, but I think that is their profession. But I think we have to take inspiration from such people. So thank you once more for patient listening. And I'm happy to answer any queries if there are.
Thank you so much, ma'am, for your wonderful presentation. We do have some question if you'd like to take that up.
Sure.
So, ma'am, the first question is, what are the implications of obesity on fertility treatments, including the success rate of assisted reproductive technologies?
Yeah, see, obesity has its impact on reproductive medicine, and as I've already told that these patients, if we have to induce ovulation, they may require more gonadotropins. Even the dose of clomiphene and letrozole has to be more. And then obesity is associated with polycystic ovarian disease. So if you want to really deal with polycystic ovarian disease, then you have to do it in a multi-directional way. So weight control is one of the things which will be like an adjuvant in your infertility treatment. So that is important. Then even diminished ovarian reserve is if you want good response in diminished ovarian reserve, then these patients should have an optimum weight. So there again it is important. Then recurrent pregnancy loss. Again, there also it has been suggested that directly or indirectly, in 50% of patients with recurrent pregnancy loss, obesity has a role to play. So here again, I mean to say, address the problem of obesity, then this problem will go away. And ART results also are not that excellent in patients who are obese, whatever, whether it is PCO or whatever reason it is, the results are not that great. So very important to address the problem of obesity. But mind you, one thing I would like to tell you, that it is very easy to preach that yes, you lose weight. It's really not that easy to lose weight. So what I would suggest that you don't delay the fertility treatment. You encourage, let them do the exercise, and maybe it will be a good idea that if you in your own center you have an area where patients can do the exercise and have a good dietary advice, and at the same time keep treating these patients, and their infertility treatment should not get I mean to say be delayed a lot. So don't delay that, just first go and reduce the weight and then but of course if she's morbidly obese, then I would say that bariatric surgery is important. Then, but bariatric surgery, one of the problems that I've seen after bariatric surgery is that their AMH goes down drastically, and even ovarian reserve in patients goes drastically. Those who are PCOS, they become okay because they become like normal responders. But those who are at a borderline and then they go for bariatric surgery, the ovarian reserve really goes down. So maybe it is a good idea to check their ovarian reserve beforehand, then do the oocyte retrieval, make the embryos, let them go and reduce the weight, and then once the weight is lost, they are better. Maybe say 9 months or 1 year after bariatric surgery, you transfer the embryos. So that can be one of the policies. So do think about the ovarian reserve before sending the patient for bariatric surgery.
Thank you, ma'am. There's another question. How does rising obesity impact the long term gynecological health of women, particularly concerning conditions like PCOS and endometrial cancer?
Yeah, PCOS, one thing is infertility, so that's not long term, but there are lots of long term problems associated with PCOS. One is psychological problem, which is really people don't understand that PCOS is associated with psychological problems. But if you talk to the patients, you'll understand that it has, these patients tend to have more psychological problems. Then these patients in the long run tend to have diabetes. Maybe not now, but years later because they have insulin resistance. So diabetes with all its other metabolic effects may be there. These patients, they tend to have lipid abnormalities, dyslipidemia. So all sorts of cardiac failures are associated with obesity, and sleep apnea is very common. So sleep apnea in these patients will also lead to other metabolic problems. So we have to address the sleep apnea also. So that has to be sorted out. And endometrial carcinoma, because there is excessive estrogens. So these excessive estrogens tend to are unopposed. There is unopposed action of estrogens on the endometrium. So incidence of endometrial carcinoma is also high. And in the long run, these are the patients who tend to have menorrhagia. And I, because now I've been practicing since long time, so I've had patients who have come to me with PCOS, infertility. I've treated that their children are now 19 years, 20 years, and now they are coming with menorrhagia and they are ending up with hysterectomy. So all sorts of other problems, fibroids and endometriosis, adenomyosis, all these things are also there. So yes, obesity does have its impact in the long run also, not only just today. And one more thing I'm forgetting, and which is actually neglected, whenever we do ultrasound, there is fatty liver reported, and we really don't bother about that fatty liver. But there have been reports that these fatty livers can ultimately end up in hepatic failure, and these patients may need liver transplant. So instead of letting them to go to such a morbid stage, I think it's very important to get alert of fatty liver, and timely intervention may help with the worsening of liver problem.
Thank you, ma'am. There is one last question. So, what strategies can be employed to improve the postpartum recovery and long term health outcome in obese women?
Yeah. So for postpartum recovery, I think it's very important, first of all, not to let these patients put on a lot of weight during pregnancy itself. So every time the patient comes, it's very important to check how much weight she has put on from the baseline. And every time, what is the incidence of weight gain. And if you really sensitize her a lot, then she will not put on that much weight. Then another thing is after delivery, in our country there is a tendency to make big laddus for them, and I think that was a very good practice long time ago when diet was so calorie deficient. So that time, if these laddus were taken, that was a good thing. But nowadays, I really instruct the mother-in-laws that if you really want to, because it's a social thing, they are showing their affection through laddus. But then they should be of a very small size. And then if she's having that, then that time the meal should be replaced. Don't take the laddus at the same time, take the meals also. So that should be kept in mind. And a proper diet advice should be taken from the dietitian. And if you control the diet, take healthy food with a lot of protein, lots of fiber, and lots of liquids, water, because the woman is lactating, so she needs liquids. So if she's well hydrated, then that will help in the milk production also. At the same time, that will not let her put on weight. And then postpartum rehabilitation, in the sense that she should be encouraged to move even after cesarean. It is not that they cannot move. So try to first of all do the cesarean in such a way that pain management after the delivery is very good, so that patient ambulates early and starts her exercises early, and they should be encouraged to the exercise. So before she leaves the hospital should have some policy about physiotherapist visiting the patient and then advising her what exercises she's doing. And then again 6 weeks after, when she comes to your postnatal clinic, it is very surprising that patient left the hospital after the labor at the weight of 60, and then by the time she comes after 6 weeks, her weight is 66, 67 kg. So they start eating much, that no, I have to feed, so I'm eating more. So you have to really discourage such habits and encourage lots of exercises, and that will help the patients in long term. And again, if this patient has had gestational diabetes, then please do a glucose tolerance test 6 weeks after the delivery, so that if it is there, it can be picked up and that can be maintained very well.
Thank you so much, ma'am, for answering all our questions. That's all from our audience, ma'am. So, ma'am, before
Thank
concluding,
you.
any last message or any take home message from your end?
I think obesity is a very high risk factor in our community. We all have to, especially our Indian diet is such which is high in calories. So we have to really sensitize all our patients, ourselves, everyone, that please eat food which is high in protein and high in fibers also, and should avoid lots of calories and lot of fried food and carbohydrates with high glycemic index. So all these things should be there. Exercise is very important, not only to keep the weight, but even psychologically, these endorphins will keep you good. And for longevity also, it will overall make you healthy and happy person. So good weight management in life is very, very important.
Thank you so much, ma'am, for joining us today.
Thank you.
It's been a
Thank
wonderful
you.
session, ma'am. And with your permission,
Thank
ma'am,
you.
I would like to conclude today's session. Thank you once again.
Thank you.